I use simulation in the department that I work. I use it in situ simulation, which means that the simulations are run during the working day in the working place.
Simulated scenarios and debriefing sessions are essential tools for medical and surgical training. One key approach is by running sessions in the workplace, followed by a group debrief.
The programme I run is called the SPRinT programme. So it's targeting team training, crisis resource management training. Most of the professionals involved in the simulations which I run are senior professionals. They know what they're doing. They don't have problems not knowing the management of patients. But because it's a very complex environment requiring input from cardiology, surgery, anaesthesia and intensive care, it can be challenging sometimes to manage crises. So that's why it's very important in our workplace to do this in situ simulation.
Good afternoon, Jim. It's Ivan, your nurse today. How are you? How are you feeling today?
Oh, I feel awful. My chest hurts, my heart's racing. Can you call my wife, please? I'm
gonna do it now, but before, just let me put some oxygen on and I'll give her a call, okay?
My chest, oh, my heart's racing.
Yeah.
Please call my wife now, please.
Yeah, I'm gonna do it.
Oh, what's happening? Oh, please get the doctor. Please, I'm worried, please get the doctor. Oh, I'm worried about my wife, please.
Yeah, I'm gonna call her, don't worry.
Oh, my chest.
Yeah, do you have
I feel dizzy.
Do you feel dizzy?
Yeah, oh, please, call my wife, please.
Okay, just gonna call the doctor 1 second and afterwards I'm gonna call your wife, okay? Hello, I'm Ivan on the James Trotter room. Could you please brief the doctor to come in as soon as possible? Thank you. Hello. So,
what's going on?
this is Jim, day 3 post-cabbage. He's complaining about some chest pain and pounding.
Okay.
So,
Oh, my chest. Oh, are you the doctor?
Yes, hello, how are you?
Oh, my heart feels like it's racing. Somebody, please call my wife. I'm worried about her, please.
Okay, where is your wife?
I think she's in the canteen.
the blood results for today, okay?
Oh, I feel dizzy. Oh, I feel sick.
Okay. I will have a look at you, okay?
Hello.
Please.
Please contact the nurse in charge and try to find Jim's Trotter wife, please. Thank you.
Oh, I feel dizzy. Oh, please. I'm
Can
so
we
worried
get some
about my
fluids,
wife.
please?
Yeah, which one do you want?
Oh, I feel
No,
dizzy.
saline.
Okay.
Oh, I'm so dizzy. My chest.
Yeah.
It looks like
Yes,
maybe
we will
something
do
else
your
is going
wife,
on here.
okay?
Can I do anything?
Oh, my
Uh,
chest hurts. Oh, it feels so
I'm just gonna
tight.
start drawing up some fluids because she asked me. Do you mind doing that?
I'll do that.
While I'm doing
Oh, what's going to happen to me? I feel like I'm going to die.
Do you want me to do have this ECG? I
Yeah.
have to see.
I will
Oh,
have
am I
a
going to
look
die?
at that. Can you get some amiodarone ready, please?
Yeah.
Please, I feel so dizzy. My chest hurts. Oh, where's my
Get
wife?
some fluids, some potassium, some magnesium.
Please, I want my wife, please. Oh, I feel sick. Please do something,
In a moment
please.
you feel better. You get some fluid now?
Oh,
Fluids are running in.
I feel
Okay,
like I'm
thank
gonna
you.
die.
Do you want me to do?
Where's my wife?
Yes, it looks like. We get down.
Please.
Potassium, magnesium.
Hello, mister? You are okay? Hello? He's not responding. Hello? He's not responding. Let's get shocked him.
Do you want me to do anything else before?
No. And get the amiodarone ready, please.
Here's some magnesium. Would you like me to give some magnesium?
Yes, please. But get the amiodarone ready.
Okay, I'm just gonna shock
Yes.
him. Okay. Charging. Everybody clear?
Yes.
Shock.
What's going on here? Why hasn't anybody called me? This is my patient. Mr. Smith, why hasn't anybody secured his area? Can you
We're
put
about
the
to
bed
shock
down. Can you put some airways in here? Why hasn't anybody called me?
We're about to shock. Do you mind stepping once?
Have you got amiodarone ready?
I'm just
What-
doing that now. I'll just do the amiodarone. Here's the potassium.
Okay,
Can we put
thank
some
you.
oxygen back on, please?
Whenever the fluid gets finished.
Thank
Can
you.
we position the patient properly? Why haven't we gone? Who's leading this?
Do you know the dose of amiodarone?
Why haven't you asked for any help? Why didn't anybody call me?
300.
When did this happen?
Just now, suddenly.
Okay, has the patient's family been informed? Do you know this?
Yeah, we've called the wife a while ago and
Was
nothing to
asking
explain to.
for his wife the whole time.
How many shocks have we given? Have we given one?
Two.
Where are we now?
The second shot, and it came back to sort of
How's the
silence.
drugs doing?
I'm just working on the amiodarone.
Okay, why isn't there anybody else to help you? Can we ask for some more people to come?
Yeah.
Is that
Do you want
possible?
me to call
No,
someone?
I'm just gonna
I
call.
gave some fluid
You said
already.
300.
You gave some fluids, okay. Well,
Hello,
and we've given 2 shots.
Yes.
A best call to
The airway,
please.
okay, let's go from the beginning. Can we get some more secure airway? Have you got any drugs ready?
Here's the amiodarone.
Quickly, quickly. Now, can we get the bed down and get the patient in a decent position?
Yeah.
Ooh.
So,
Right. So, can we just check and do a proper assessment this time?
Yeah. Ice is there. It's around 100.
Now, the blood pressure is too low. Can we check the blood pressure again? Is that continuous?
Is that continuous measuring blood pressure?
just touch the screen again.
Can we put a call out? This is ridiculous.
I just
Where is these people that were supposed to be coming to help?
You know.
This is the amiodarone here. Does anyone know how long we give it over? Is it
Okay, now,
30 minutes.
30 minutes? Okay.
Mr. Smith?
30 minutes.
Ice is around 100.
Mr. Smith? You alright?
Okay, this is now ready. We
Okay.
can give it over 30 minutes. Do you want me to
Okay.
stop the fluid?
Yes, please.
We use the advocacy inquiry method of debriefing. We found great success with it in the way when we've evaluated participants who've undergone this training. We've had very good evaluations. It's quite a direct way of questioning and it works on an observation that the debriefer sees, which is relevant to the care of the patient and also has relevance to team training. Having asked that question to a participant, it's then important to confirm that the deduction of the answer to that question is understood by both the debriefer and the participant. And this is what we take great efforts to make sure we've got the right thing. And then we throw it out to the whole group to confirm that other people have experienced the same experience in different scenarios in their life. And then it is up to the group to find a resolution. So as debriefers, we try not to talk, well, we try to talk very little and to get the group to come up with the solutions. And that's, we've found that that's been a very good way for the participants to actually learn rather than us just teaching them. Thank you for participating in the simulation scenario today. I'm Margarita, one of your debriefers, and Julie is the other debriefer. What we're going to do for the next 45 minutes is just go through that scenario. First of all, we're going to discuss feelings, and that'll take about 10 minutes. And then I'll review the medical facts, what actually happened to the patient. After that, we'll spend about 20 minutes analysing some of the actions that happened in that scenario. And how we debrief is using the advocacy inquiry method that we've been trained from the Harvard Simulation Centre. So some of this demands some direct questioning. Do not feel that we're actually getting at you. It's just that it's a tool that's useful to bring out the processes of team training that we want to do. And after that, I'll summarise what the medical facts were and what team training roles that we've discovered in this session today. First of all, I'd like to know how did that go? How did it feel for you?
We were trying to get hands on a lot of things, but we couldn't manage to get everything at the same time, so a little bit stressed.
I didn't think it was great. I was disappointed.
It was really confusing for me because the patient was asking about his wife all the time. and I didn't know what to do. He was distracting me from doing anything.
Well, I walked in, it was a disaster. I just got angry because I could see that half of what should have happened hadn't happened. So that made me irritated. So I may have come across a little abrupt at the time.
And is everyone clear what the medical facts were?
I'm not really. I felt like I just sort of walked in and got asked to do lots of things, so I just got on with jobs. I really don't know what was going on with the patient. But he was okay in the end. He was speaking, so I thought that was quite good at least. That was a positive thing.
Suddenly, he started to complain about chest pain, bounding, and seems to me that he was a little bit confused because of, I don't know, whatever. And then I did a 12 leads ECG and I could see that he was on very fast AF. So mainly that was the reason. And we
Yes.
had to cultivate that.
1 week after a cabbage repair, he's been in AF, he goes into fast AF and needs the algorithm of treatment, the shock and the amiodarone, which I think everyone here knows. Okay, so is everyone absolutely clear about the medical facts? Are you are happy with the way that those have been described? So what we'll do now is we'll start asking our advocacy inquiry questions, and I'll hand over to Julie, who will ask the first question. Okay.
Lovely, thank you. Lydia, you said that when you entered the room you didn't really know what was happening and you were given lots of tasks to do. And one of those tasks was to draw up some amiodarone. However, I observed that you didn't draw up that amiodarone even though you were asked to do so. And that concerns me because there could have been a delay in converting this patient from a atrial flutter into a sinus rhythm. Can you tell me why you didn't draw up the amiodarone when you were asked to do so?
Well, I was asked to do a lot of things. So I heard that I was supposed to draw up some potassium and some emergency drugs and amiodarone as well. So I did the potassium and the magnesium as well and got some fluids. That was the first thing I heard. I was quite clear about how to draw those things up. So I didn't get to the amiodarone, but I felt quite stressed, and actually I forgot the dose of the amiodarone, so I just decided that I would get all the other things done first, because the doctor asked for all of those things, so I thought I would just get the other things done first, and then eventually do the amiodarone. Maybe I could think of the dose eventually.
Yeah, okay. So you're telling me the reason you didn't draw up the amiodarone was because you didn't know the dose and you felt quite stressed during this scenario, during this situation.
Yes, that's right. I didn't remember the dose and I felt quite stressed, so that's why I didn't draw it up at the time.
Okay, thank you. Can I ask the rest of the group, has anyone else been in this situation where they've had to remember a dose for a drug that was very important for the patient and they couldn't remember that dose because they felt quite stressed in the situation that they were in?
There's been a lot of time that you're trying to do something, and because you're under stressed, you sometimes just completely get blanked and you don't know what to do. But sometimes just asking all the colleagues and just find whoever is the seniorest one to ask what's the correct dose or whatever you have to do, and then when they're giving you the answer, then you just go straight away and do it.
Anybody else been in that situation before?
I remember a particular situation. A patient was on the table. I walked in. I just had to shout for somebody to look it up for me. Just ask for help. There's plenty of people around.
Yeah. It felt like a real emergency, that situation, but whenever it's not an emergency and I don't know a dose, I would look in the BNF or the guidelines from the trust on the ward. That's what I would normally do, and I just didn't even think to do it at all, actually, and I thought they're very busy, so I don't want to interrupt them, but that is what normally would happen.
Yes, absolutely. So you've identified different ways that you could manage this situation in the future by asking your colleagues for the doses. and also using other resources such as guidelines and other BNF or other methods of identifying where the dose, what the dose is for a particular medication.
Yes.
It was obviously quite a stressful situation, and you were being questioned a lot by the patient.
Yeah.
I noticed that you didn't call for help. And this concerns me because some of the treatment was delayed, for example, the oxygenation of the patient. So I would have been interested if you could tell me why you didn't call for help.
Yeah, I was so confused by the patient himself, so I just stopped to do the normal things, and I couldn't even remember anything.
Okay, so so the situation of the patient calling you confused you,
Yeah.
so you couldn't think clearly to call for help. Okay, is that
Yes.
it? Right, has anyone else ever been in the situation where something like calling for help, which is quite important, it hasn't occurred to them to do that because they've been distracted by various events? In this situation, a patient asking other needs of the carer. Has anyone been in that situation before?
When I've worked in paediatrics, actually, because you have the families to deal with and everything, it can be really, really tricky because the child might need urgent help, but the mother is becoming very emotional. And I found in those situations that although you can initially try to help with the emotional support, you have to really focus and prioritize only on your patient and using sort of the ABCDE algorithms that we're all taught and we learn quite well in our advanced life support classes and things. So for me, having to really focus and try to put away those distractions of family can be quite important, I think, but it's really hard.
Pediatric wards are notorious. I had a very difficult grandmother once who wouldn't leave the patient, and the patient was clearly deteriorating, and she was clinging on to this child, so we had to then get the family liaison people to come in to get somebody else to deal with her because we were too busy with dealing with the patient who was crashing at the time.
My next question would be, what is the solution to this? Sure, you need to be focused, but sometimes the distraction is so great, you lose that focus. So handing over the role to someone else, like a family liaison officer, is one of the solutions that can be considered. Anyone else got any ideas for a solution when you have a patient constantly demanding something of you, or a parent or relative, so that you can't actually do your medicine or nursing?
I just have one completely dedicated to help the patient or the family or whatever, just to make sure that everything they need, it's been given. So just as one of our staff to be trained and then help them in those situations to go through and make them easy.
So having a named nurse, for example, whose role that is, so we can have delegate a role during that time, call a family liaison officer, have a dedicated nurse whose role that is. Is there any other member of staff you think that most departments will have that you could dedicate that role to? Because you might need your nurse who's got the dedicated to actually be bagging.
We didn't have enough nurses, did we?
Where I used to work before, we used to have a very good ward clerk. She had a very big role in dealing with the parents, so she would step in. But it was always part of the resus team.
Yeah, so maybe even considering a healthcare assistant or a ward clerk, giving them a little bit of training, they could be someone who could fulfil that role and then relieve the rest of the medical and nursing team to care for the patient. I think I'll wrap up now. What I'll summarise is today we've done a scenario of a man who was 75 years old, a week after a cabbage, who went into fast AF and needed shocking and treatment, including airway treatment and amiodarone infusion. We've talked about two key crisis resource management principles. The first one was about knowing what your resources are and maybe adapting the resources in your department so that that well-known, recognised problem of just blanking out on what even an emergency dose is can be covered by looking at a guideline or having internet access or BNF access to dose. And the second one is how to remember to call for help or do something basic in a resuscitation situation when you're being distracted, and a common distraction being the patient or a relative distracting you, trying to find role allocation for those that performance by another member of your team. So these are two important crisis resource management principles amongst the ones that we've discussed earlier, with leadership, role allocation, knowing your resources, and standing back and assessing the whole situation, that will ultimately help change the outcome of the management of a patient, where everyone knows what the medical and nursing treatment is, but the performance in a combined team to improve that will be better. So thank you very much for coming today, and I hope we've all learned something. Thank you.
Thank you very much.